Welcome, everybody, to the Sapien podcast. I am Dr. Gary Schliffer. I'm an internal medicine specialist focused on integrative medicine. And today I am so lucky to have Dr. Ben Bikman on the podcast. I have been a follower of Dr. Bikman since I started my journey to learn about nutrition after medical school, after internal medicine training. And Ben has been a huge inspiration. He's a professor of cell biology at the University of Brigham Young University and holds a PhD in bioenergetics. Correct, Ben?
Yeah.
And he is an author of a really amazing book that everyone who's listening to this should read, Why We Get Sick. And Ben, thank you so much for joining us.
My pleasure. Yeah, Gary, thanks for reaching out.
I have been following you since the beginning. Most of my listeners at this point are people that followed Food Lies, Brian Sanders, and our spin-off podcast, Sapien Podcast. And season 3, I've taken over. Brian's busy doing all sorts of exciting things and getting that documentary out. And just for your knowledge, I am really focusing this season on the integration of the mind-body-spirit connection. But I anchor everything in nutrition because that is really the foundational component of health in my eyes. It is, if you don't eat correctly, nothing else makes any sense. I know you've had a journey. You didn't start necessarily talking about food and metabolic health. Can you tell us a little bit of how you came to this, and then we'll get into it?
Mm-hmm. Right. Yeah, my background really started as an academic or as a future scientist. It started because of a publication I found in the early 2000s as I was starting my master's degree in exercise physiology. So at the time, I knew I was interested in the body. I knew I wanted to learn more about the body as a career. And my interest was on the muscle, where I thought I want to better understand why is it that muscles get better, faster, stronger with training? What is the mechanism of the adaptation? But in the process of learning more about the body, I stumbled across this paper that I just mentioned, which outlined the fat cell and its role in contributing to type 2 diabetes. Specifically, it presented the data that, in my mind, created a very beautiful paradigm and series of events, namely that the fat cell gets big, it becomes pro-inflammatory, and then the inflammation then causes insulin resistance. And the insulin resistance is what contributes to type 2 diabetes. And then, as I would later find out, chronic disease in general. So that manuscript really it planted in my mind a very deep-seated interest in insulin resistance, a problem that I was very unfamiliar with at the time. But it somewhat reflected still this overall interest I had in metabolism, which is almost this competition of substrates. Like, how is it that fat, in particular, the lab that I ended up going to for my PhD in bioenergetics was a lab that was focusing on lipid-induced insulin resistance, which has given me a lot of, and then I followed that up with my postdoctoral work, specifically looking at how lipids drive insulin resistance by activating immune pathways, or inflammation, in other words. And that is an interest that has only grown. It's certainly evolved, but what has not changed is my interest in insulin resistance. In fact, the only change over the years since I've been a professor and running my own lab has been that I appreciate insulin resistance even more than I did. Whereas I used to only view it as something being relevant to type 2 diabetes, specifically being the foundation of it. Now I appreciate that it is foundational to virtually every chronic disease. And that was certainly the intention with my book, but that has been part of the evolution in my career as a scientist, where it was a very deliberate series of actions on my part to want to step out of the ivory tower of academia, where life is increasingly artificial, where science is content to live within the realm of the theoretical. And I rail against such a paradigm, such a view. I believe that if we aren't making contributions that have a real world application, then we're wasting time. That sure, there's something romantic about the idea of learning for the sake of knowledge. Yes, that sounds wonderful, but then we're just wasting time and money if we're not actually trying to translate knowledge and new discovery into tangible um, interventions to
Hmm.
improve people's lives, then I think that we are not realizing our potential as academics. So that just touches on some of my evolution, and not only with regards to my focus on metabolic health and insulin resistance, but also my efforts and interest in being on a podcast with you, Gary, where I don't want to keep these ideas in a classroom where they have limited value. I believe that the true impact can only be realized when these ideas are shared out of the ivory tower into the real world.
Thank you. Because as a physician, as a clinician, as a young doctor who started practicing medicine 7, 8 years ago and started asking the same questions you were asking and very focused on clinical practice. I have hundreds of patients in front of me every day, every week, every month. Like I have a very high volume practice, and I'm trying to give meaningful feedback, right? And I really anchored on this idea that the pharmaceutical industry really just hijacked my profession. I watched it happen, and later have read amazing books. Uh, just learned so much about how my profession got taken over, and it was Ted Nyman, it was our low carb community online that started giving me meaningful interventions, meaningful concepts that made sense, not just, hey, I learned a bunch of stuff in biophysiology in med school, and then I got a bunch of crazy recommendations that had no bearing on the basic sciences and I'm a scientist. I did a bunch of work in neuroscience, almost did a PhD. I'm very grateful for academia and the research science community. I hold it to a very high regard, but it's that same frustration of they learn stuff, they publish stuff, but to get it from a concept in your mind to clinical practice to help millions of people who are struggling with obesity and all the chronic medical issues. I just couldn't wait. I couldn't wait another, I don't know, is it ever going to happen?
Mm-hmm.
And so I wanted to bring you on to show some of my listeners this is the kind of person that's out there putting their neck on the line, sharing this research. And I think when you send your message of eating a low carbohydrate diet, of promoting, whole foods, of pro animal foods, and I know, I follow you obviously, so I know and I really, again, encourage everyone to listen to your podcast, because listen to your channels and read your book, because it is just so informative. But it's like, without you, I cannot help people, and I wouldn't be in a position to help people. And now in my clinic, I see we reverse type 2 diabetes. We have these dramatic responses to autoimmune diseases. I always thought Crohn's disease was irreversible. That's not true.
Mm-hmm.
It's just not true. And so, how is it that academia has it so wrong? How is it that the recommendations are just so disconnected from reality? Because it's not like what we're talking about doesn't have huge anchoring in real foundational science, basic science. How is it such about, and also, how do you do it? I mean, is BYU just incredibly supportive of you? Have you found, I'm just always surprised because there's so few scientists out there.
There are, yeah, and there are hurdles. Yes, so thankfully BYU is totally committed to academic freedom for its faculty, and I've been very proud of my institution for that. But it's not been without some internal conflict, and I'll be careful talking about this. But even here, I have had faculty who have deemed my views offensive and have tried to get me quieted. Thankfully, the institution has supported me every time, in part because of my own contributions. I am the scientist here. I'm the one who's actually publishing peer-reviewed manuscripts on these topics. So, nothing in this realm. There's nothing that really matches the defense of data that you can't ignore. That in my case, I've created explicitly, but there is a certain degree of diplomacy that needs to come with it, or that should come with it. I'm a kind of guy where I won't back down from a challenge, but I also would rather not create a scenario where it is open hostility. And the way I have approached these kinds of topics, rather than leading with the message that we've gotten it so horribly wrong over the past decades because we eat high carb, high refined oil diet, which is really the problem.
Mm-hmm.
I don't start with diet. When I try to have a conversation like this, knowing that diet is such a polarizing topic, I actually start from my true area of strength, which tends to not be someone else's area of strength, by specifically informing people about insulin resistance.
Right.
One of the reasons I start with that is because my thought is, if I can have a conversation with someone and we come to a common understanding of acknowledging the prevalence and relevance of insulin resistance, namely that this is the single most common health disorder worldwide, and two, it is, if not the main cause of these non-communicable chronic diseases, it is a common cause, but it is a main cause for many of them, then that starts to frame the subsequent conversation in a very palatable, less hostile way, where I can say, this is insulin resistance and it's a really, really big problem. They can look at that, they can hear me say that, and they say, I see. Okay, I think you're probably right. It is a real problem. What do we do about it? That becomes the next step. And then I usually will transition into, well, these are the primary causes, and these are the other contributing causes. And what the drum that I beat the loudest, because I really do believe, now I'm using the word believe, which is not a scientist's favorite word, of course, because I have to speculate a little, because these kinds of, there's not been studies that have explicitly quantified the efficacy of interventions pitting against each other. But of all the contributing factors of insulin resistance and all of the interventions that you could do to mitigate that, the drum that I beat the loudest is hyperinsulinemia. That living a life that is spiking your insulin too frequently, which everyone does, because of what they eat and how frequently they eat it, that's going to be the main contributor to insulin resistance, and thus addressing that will be the main therapeutic cure, where addressing diet is either the culprit or the cure. But one other comment that I wanted to make was, when I'm able to frame the conversation with the starting point of insulin resistance and then progress into diet, that is certainly not to say that there's consensus there. Among the anti-meat crowd, the sentiment is that if you eat too much saturated fat, particularly from animal sources, then you will clog the insulin receptor. That's what they'll say, or you'll block it, which is a remarkable statement to make, and one where we should hear that and say, well, how does it clog it? And there's no mechanism for that. There's no answer there. I am very sensitive to that perspective because I have published papers on that topic. As I mentioned at the beginning of our conversation, my whole postdoctoral work was exploring the degree to which saturated fats uniquely contribute to inflammation at the cell, not at the whole body, at the cell, and how this contributes to insulin resistance. But too many people will look at that kind of study and say, thus we don't eat saturated fat. That's not the same thing as eating saturated fat, where Jeff Volek's group at Ohio State published reports finding that if you had saturated fat consumption multiples higher than another group, but it was in the context of low carb, the actual amount of circulating saturated fatty acids in the plasma went down. Not to mention inflammation markers went down. So there is this either willing or ignorant overlook of the fact that they have a little bit of truth in this kind of anti-meat, plant-based perspective. There's a little bit of truth, and they've unfortunately extrapolated well beyond what their expertise would allow them to. But I'll just say, any intervention that takes a person on a standard American diet is going to improve insulin resistance. So I would never argue the fact that the plant-based advocates, the anti-meat advocates would say, oh yeah, well, look what happens when we take people from a standard American diet. Do anything to that diet and it's going to be better and you're going to see improvements. That's not what I care about. I care about what's the single best intervention. And if this is a disease that is heavily affected by chronically spiking your insulin, then there is one class of macronutrient that should be scrutinized. And that, of course, is carbohydrates, whereas the other two should be given a much more liberal view, in part, if for no other reason than because they have little to no effect on insulin, namely fats and proteins.
Thank you. And my patients listening are going to be like, oh, this is where Dr. Gary got it from, because I honestly repeat the stuff that you just said to my patients over and over again, because I agree with this idea that if you start a conversation about health with your dietary choice, it becomes almost like a religious battle, right? Like, oh, I believe this and I believe that. And so, sure, yeah, in science, we can't anchor on beliefs. So we do have facts. We have really great research about how our hormone systems work and how it responds to macronutrients and various fasting strategies and various stressors like cold therapy and high intensity interval training and all these interventions and how they affect our hormone system. And so I always start there. I always start with teaching people about hormones and the mechanisms that those hormones are manipulated. And I think I do that, one, same reason, to sort of dissuade the argument about food and focus on what's really going on. But also because I think that the insulin resistance contributing to chronic disease also contributes to, like, I wanted to get into it, but mental health issues, anxiety issues. Ultimately, dementia is a metabolic disease, and there's amazing research being done in a great book called The End of Alzheimer's that is already starting to present some of that data. So for me, as a primary care physician and people coming to me with nutrition, it's about where do I start to teach them how all this stuff comes together. And for me, that's hormones, right? Hormones are these fat cholesterol-based molecules in your body that communicate. They connect the dots and they connect all of this stuff. And when we look at insulin as just type 2 diabetes or type 1 diabetes, there's no insulin. There's insulin as a part of everything, as is cortisol and adrenaline and even vitamin D, though is a pro-hormone, in my opinion, one of the most important hormones to think about. And it's like that anchor. Now, what I wanted to mention was my battle with physicians, because my patients come to me and they're going to listen to this podcast, and a lot of them are looking for support. What do I say to my family member, right? What do I say to my cardiologist? And then I struggle with, what do I say to my colleagues, my cardiologist colleagues, my nephrologist? And what I often do is I give examples of how, you recommend a low salt diet, and then when my patient goes to you, you give them salt tabs. It's like, well, that doesn't make sense, doc. Like, that's like a lot of my kidney doctor colleagues. And then I have, my cardiologist, I'll send a patient that had an MI many, many years ago, a heart attack many, many years ago, and they've changed their diet, changed their lifestyle, fasting insulin's down, A1C's down, and they're pummeling them with LDL lowering drugs. And I have to go in and start communicating to patients about how the lipid hypothesis makes no sense. And that is my biggest battle, to be honest with you. The plant meat thing that we sort of all started with, and that is still an issue. In my practice, people get it. I think more and more people are getting it. There's a big change in the stores where you're getting a lot of like organ meat blends, and you're getting a lot of grass-fed, grass-finished, pasture-raised products. People are, like the bells are ringing. People are seeing that. But when they go to their specialist and their doctor is like, well, unless your LDL is less than 70, you're going to be at high risk. And I'm like, oh my God, who has an LDL less than 70? Because I can show you hundreds of incredibly healthy people. And what you see is a very healthy triglyceride HDL ratio, high HDL ratios, low fasting insulins, low CRPs, low morning cortisols, excellent sleep habits. Like, these are the things that matter. So can you speak to, because you already spoke to the saturated fat, this HDL, LDL, you had just recently posted Dr. Fung's study looking at non-HDL cholesterol. Maybe you could speak to that. But like, this is something people ask me about all the time, and it's so critical they understand that this LDL, total cholesterol stuff is, in my eyes, nonsense. Unless you're terribly ill, you've had lots of disease, you're terribly sick, you're not interested in making lifestyle changes, you're not interested in doing those things. Okay, take 20 drugs, let them do what they have to do to decrease your risk. I don't practice that way. What do you say? Like, how do you present that to people to ask you?
Right. This is a timely question. My class, my primary undergraduate teaching assignment is a class called pathophysiology. So some people listening might have taken this. The physician will take pathology, but the version I teach is pathophysiology. So rather than how the tissue looks when it's not working well, we study more about how it's working when it's not working well. And we're just about to get to the blood vessel disorders lecture. And at that point in the lecture or in the semester, I um, I ask the students to just humor me, and I say, what I'm about to teach you for the next 30 minutes isn't on the test, but it's basically a dismantling of the lipid heart hypothesis, which you alluded to, that eating saturated fat will increase cholesterol, which will increase atherosclerotic plaque formation, which will increase heart attack risk. That really is the theory, or the hypothesis. And unfortunately, what has happened, not only unique to the lipid heart hypothesis, but in many other areas of medicine and science, the hypothesis has become embraced as fact, without ever undergoing the rigor of scientific inquiry and intervention that you would need in order to establish it as close to fact. The scientific method is this ongoing process of continually attempting to prove yourself wrong. This has never been more obviously not the case, with the explosion of COVID and this explosion of an obsession with science, more as a religious creed than it is a pursuit of truth, and through a skeptical process, constantly questioning yourself. It really has become a declaration of faith now to just proudly proclaim that you believe in science. And the irony is that's a very unscientific way to speak. Now, nevertheless, with lipid and cholesterol, we just have to make sure that the audience is aware that every single conclusion on this topic is based on correlational interventions, or rather, there's some aspect of correlational conclusion where you have to just make some assumptions. Some of the most compelling data comes from some very large institutional studies done decades ago, in the 50s or so, which had people eat diets of these were people who were in fact institutionalized. So they had total control over their diet, a study that you could not get approval to do today. And they followed them for years. They had one group eating in a cafeteria that had high saturated fat, the other group eating in a cafeteria that had high polyunsaturated fat, like the fat from soybean oil, etc. That group, the high soybean oil consuming or seed oil consuming group, they had lower cholesterol levels, which often will happen if you eat these polyunsaturated fatty acids from these seed oils that are high in phytosterols. It will tend to reduce normal cholesterol, the human sterol rather than the plant sterol formed. It will reduce cholesterol levels. And if that hypothesis was accurate, that more cholesterol caused heart disease, they should have died more. In fact, they did not. The group that had the lower cholesterol, indeed, they even quantified it in one of the studies. It was either the Minnesota coronary experiment or the Sydney diet heart study. One of them quantified and found that something like for every 30 milligram per deciliter reduction in cholesterol, there was like a 20% increase in overall risk of just dying from anything. So they were dying more. And across a handful of correlational studies, we see this consistent theme that the lower the cholesterol, the more likely the person is just to die, or they have higher risk of cancer. They have a higher risk of Alzheimer's disease. This is because we have vilified cholesterol, and yet it is absolutely a molecule of life. It is involved in so many fundamental processes, some of which you've already mentioned, including lipid hormone production, all the sex hormones. Aspects of the mitochondria are based on cholesterol. Vitamin D is based on cholesterol and everything it does, and more and more. So declaring war on a molecule of life that is so fundamental to life is just foolhardy and silly. What then matters? And you've touched on it. I published a paper with Paul Mason and David Diamond last year, where we found that regardless of what someone's LDL levels were, high or low, didn't really have any impact on their heart disease risk. What did is if they had this high triglyceride to HDL ratio, basically. The high triglyceride to HDL ratio is actually a reflection, not that even that is a direct contributor to plaque formation, but it reflects an overall unhealthy metabolic milieu within the body. If a person has high triglycerides and low HDL, then they very likely have insulin resistance. And that's likely a direct effect of the insulin resistance at the liver, who's responsible for those molecules. It's the liver that's making triglycerides primarily. Of course, there's some coming from the diet. That would be the chylomicron. But if a person's fasted, that is not part of the equation. So the triglycerides are coming from the liver. HDL is coming from the liver. And as the liver becomes insulin resistant and the body becomes hyperinsulinemic, which always comes with insulin resistance, there's no insulin resistance without hyperinsulinemia except starvation, true starvation. I don't mean fasting. But in that case, then the triglycerides will go up, the HDL will go down. And it's likely the insulin resistance that is the primary contributor. And that was the study that you'd mentioned that Jason Fung had shared, and a lot of us were retweeting. This big paper published, I think it was in the New England Journal of Medicine, looked at the 5 most relevant risk factors for heart disease, and cholesterol was barely above normal. I mean, it was largely irrelevant, in fact, often not even reaching a point of statistical significance. And yet type 2 diabetes was heads and shoulders higher than any other risk factor. And of course, type 2 diabetes is insulin resistance. Insulin resistance is, I would contend, the main contributor to atherosclerosis or plaque formation. Not to say it's the only one. There would be some other ones, including linoleic acid from seed oils, that are very, very likely directly contributing as well. So I don't think it's a single factor here. But regardless, once again, insulin resistance is something that connects a chronic disease that you wouldn't have imagined that has a metabolic origin.
It's surprising to me how many of my physician colleagues refuse to integrate any new knowledge into their actual clinical practice. This is what I was going to get at. I wanted you to present that so that everyone can hear that when I talk about this stuff in clinic or on my podcast, I'm not making it up. I'm following research. I'm following brilliant scientists like yourself, and we're all connected through this amazing internet, and we all share ideas. And I find like my role in this is not to create the knowledge, because I left academia behind. It is to be a bridge between the academics and the people that need the help today, not in 10 years, not in 20 years, not after they've had a stroke or a heart attack, but today. And I try to present this stuff. And I try to present it to my colleagues as well, and I get pushback. So,
in fact, Gary, let me just add to that. This is how I believe it works in its most perfect form. You have the biomedical scientists who are making these discoveries, but the discovery on its own is largely meaningless. I mean, maybe there's the off chance that the scientist has the opportunity to share it. Someone's able to take that and on their own, it has had a direct benefit. But I think the true power comes from the clinicians who are getting the information from the biomedical scientists and now putting it into practice, because that is where the rubber meets the road. It's one thing for the scientist to put some gas in the tank, but someone still needs to drive the car. And that's where the clinician comes in. It's the clinician that actually brings life and relevance to the information, because as I know very, very well, knowing something is valuable, but not as valuable as actually doing something. And that's where it gets a little hard. So when a patient has a clinician who is reinforcing this and providing a means by which they can actually start to take these steps, then I believe we've really realized the true potential of biomedical research and clinical practice.
And it's amazing, because if you come to my practice, your first set of blood work includes a fasting insulin, a CRP, a full metabolic panel is what I've called. I made it up. I mean, I didn't make it up. I listened to you and others like you, and and here's the crazy interesting part, which I wanted to share. I had a medical student who was sort of following me when I was going through, literally listening to podcasts with you, and like, oh my God, let's look this study up together. And we were going through it, and I was discovering, right? And so she goes on to medical school and now residency, and she comes back and she's like, let's do a research together. And I'm like, I don't do research. That's a lifetime ago. I don't know. But she was very adamant, very smart young girl. And I was like, okay, let's do this. I think that my patients, even if we take a small number, I think we did 40 patients, randomly pick them people that were kind of signed up for frequent visits, we did a thing where you had to do at least a certain number of visits for nutrition counseling. That's what I was kind of my model back then. And sure enough, just with an N of 40, we were able to show that triglyceride HDL ratio improve, and that BMI improve, and that insulin improve. Nothing else improved. The A1C didn't improve, the fasting blood sugar didn't improve, but the metabolism started to improve. And it was so interesting, because that's how powerful this intervention is of cutting out seed oils, focusing on insulin resistance, intermittent fasting strategies, being super thoughtful about your carb consumption, making sure you're getting enough protein. And you see these markers change, and they changed. I mean, 3 months, we started seeing them. 6, 9 months, year, how dramatic improvement. I mean, there's certain patients, you know, we all know those stories, like they are a different human being in a year. And that's thanks to changing how they eat and explaining to them how insulin works. And I am so grateful. I don't want to go off on my tangent. We were talking about this cholesterol stuff, and this is the thing that comes up all the time: statins. I know you've talked about it before, but like, again, I'm really focusing on what my patients need to hear.
Yeah.
Oh my God, with these statins and these new injectable drugs trying to drive these LDLs down to 30 and convince, and here's the thing, patients, you know, when I talk to my cardiology consult, oh, well, here's the study and it reduces the risk of this. And I'm like, but there's other research that was not funded by the pharmaceutical industry. I understand that as of 2023, less than 3% of medical research is not funded by a drug company. Since the year 2000, I think it used to be like 30-40% was not drug. Now it's all drug company studies. And I'm like, but look, guys, there are people doing this work, and the research suggests the exact opposite of what the drug companies. And then I'm like, remember what the drug companies have done. We've all seen it now. If you've been around for 20 years, you've seen them screw things up, manipulate people, get money. I'm not even going to mention what just happened in the last few years. A perfect example of that opened many eyes. Don't want to mention it for obvious reasons, but that was a perfect example. We could talk about antidepressants. We could talk about gabapentin. We can talk about Vioxx, and the list just keeps going. Drug company failing us to be honest with their research and giving us meaningful intervention. So that's the deal, you guys. The statin guidelines and these other lipid-lowering drugs are paid for by drug companies and manipulated aggressively. And can you add to that? Because that's just, I want to reinforce that idea that these statins have little to no benefit, maybe in a very sick population, but certainly not for primary prevention of disease, and certainly not for elderly people whose brains are barely working, and you need to make sure they have the cholesterol to operate their hormone system in their brain.
Yes. There are multiple reasons to be very careful with statins. You've mentioned some of them. Before I mention statins, I'll just riff for a moment on one of the problems with American medicine. I believe that the American medical situation is among the best on the planet. As much as people here in the U.S. want to just destroy America, and you know, no one hates America like Americans do, is something I've found. As a foreigner, I was born and raised in Canada, and I've lived around the world, visited dozens of countries. It's a remarkable, sort of a uniquely American attribute to think America is the worst at everything. Other countries don't feel that way. But nevertheless, one of the things we've done wrong that I think explains why our health outcomes are not better is that we're one of, at least as of a few years ago, I think this is still the case, we're one of 2 countries in the world that allows drug companies to advertise. So this is why we'll see, watching a football game. I was just watching a football game last night, and there were the majority of ads were for drug companies or a specific medication. And it is a remarkable environment where we have a patient who comes in and asks for a drug. You have a clinician who in the US nowadays needs to see more patients than ever. And so he or she can't take the time to talk about nutrition, and there might not be a reimbursement code to get paid for talking about nutrition. And so there are all the incentives to not only make that visit as quickly as possible, but as a solution as simple as possible, or a seeming solution, that would be to leave with a prescription for a drug. Now, I am not of the mind that all drugs are bad and we should destroy the pharmaceutical industry. Not at all.
Me
It
neither.
is a miracle. Yeah, it is a miracle of modern science that we have some of these life-saving medications that we do have, and that work needs to continue. And we need the rest of the world to help make it happen by paying for the drugs that the U.S. is developing. This should not be a unique financial burden placed on Americans. And other countries are sort of let off the hook for that expense, with them benefiting from these discoveries. So we need to continue the work, but not kid ourselves into picking a villain, making a villain out of a marker just because we can target it. Now, what I just said actually has higher impact than I think most people realize. So I'll say that another way. Many of the worst drugs exist because there's something in the body that they target. And so take for example the statins. Statins have a horrific track record of actually improving health outcomes, actually making people live longer. They might not die from a heart attack, but they'll die from something else, and just as likely, and their lifespan is probably not even remotely going to be extended, and might even be much more miserable because of the statin. And I'll revisit that in a moment. But why even have a statin if its track record is so poor? It's because we see that this medication will lower LDL cholesterol, so we have to make a villain of LDL cholesterol. If, for example, there is no drug that will really effectively target triglycerides. Triglycerides is a way better marker of heart disease risk than LDL cholesterol is. Why don't we ever talk about triglycerides? Because there's no triglyceride drug. If there were, then we'd be talking about this drug more. And just like glucose in the context of type 2 diabetes, type 2 diabetes isn't a glucose problem, it's an insulin problem. But because we have so many drug interventions that can lower glucose, glucose has become the marker that matters because it's a druggable target, whereas insulin isn't. You can't hide what insulin's doing. You have to address it head on. So that's largely that's at the heart of my frustration with applying a pharmaceutical intervention to what is a lifestyle disease. It is the food we eat that is the culprit or the cure. Any effort to try to mask the consequences of a bad lifestyle will only address specific symptoms, while very often making the entire problem worse. Like, for example, back to diabetes, and then I'll come back to statins quickly. If we view type 2 diabetes as a disease of glucose, then we will, for example, say, let's just push up insulin really, really high in the type 2 diabetic because it will lower glucose, and it will. And if glucose were the only thing that mattered, then we would say we solved the problem. Unfortunately, it isn't. It's the high insulin that matters in the case of type 2 diabetes. That's what's making them sick, making them gain weight, making them have an increased dementia risk and fatty liver disease, etc., and heart disease, which is why, because it's insulin that matters, actually, if you put a type 2 diabetic on an insulin therapy, no clinical outcome improves. They get fatter and they get sicker. They're 3 times more likely to die from heart disease. They're twice as likely to get cancer, twice as likely to get dementia. We're making them fatter and sicker. Now, back to statins.
I don't mean to interrupt, but if anyone is interested in really, really understanding what Dr. Bikman just said,